Welcome back to At the Heart of Health. We were answering a question about breast cancer with Dr. Brent Barrow. Dr. Barrow is a radiologist with Vista Radiology. Making a diagnosis is very important. We left it off in this hypothetical situation where we had a question about a young person that had high risk.
Right.
And now we're walking through the diagnosis. We had a suspicious mass on digital mammography.
Right.
What would be the next step?
She may have to come back for follow-up mammography imaging, potentially an ultrasound. That may clear it up, and we say, oh, it's just a simple cyst. We don't do anything about it. It may be a little suspicious, and we say this needs to be watched closely, probably in 3 to 6 months, or it may be suspicious enough in appearance that we recommend a biopsy.
Okay. Let's say you get a biopsy.
Sure.
And you find out that it is a malignancy, and treatment begins right away.
Right.
Tell me, what is the advantage of detecting this early or waiting 3 months? You know, no one likes to have a biopsy.
Sure.
You know, it's suspicious. You know, we could wait 3 months and see if it's grown. What is the advantage of picking up maybe 3 or 4 months, even a year earlier?
Oh, well, the advantages are huge, and it's all about survivability. And that's what, you know, it all harkens back again to, you know, those things that patients can do for themselves, the self-breast exam, you know, routine checkups, routine mammography. Because if we find cancers early, stage 0, stage 1, their survival rates are essentially 100% at 5 years.
Wow.
For breast cancer.
100%.
And breast cancer is the second leading cause of cancer deaths in women. But if we catch it early, survival rates are amazingly good.
You know, that's different than, you know, same with cardiovascular disease.
Sure.
Except we see cardiovascular disease setting on in the 20s and 30s. That's where that disease starts, and that's where we want to start prevention.
Right.
Now, we've heard a lot in the press about MR.
Sure.
What is MR? How does that play a role in breast disease?
MRI can be a very intimidating modality. In a breast exam, a mammogram, can be uncomfortable for the patient. And MRI, particularly for breast imaging, can be uncomfortable as well. The patient actually is positioned prone. They're laying on their stomach. They have to get into usually somewhat of a tube or an enclosed structure, so claustrophobia is an issue. And there's no radiation with MRI. It gives us, so it gives us a different kind of information, great information, but it's not a modality that we can usually use as a screening test. But to answer questions, to determine, do we think this is malignant or not? Or in maybe a patient who has had a number of abnormalities, we want to try to figure out where it is, or we know they have a breast cancer. And depending upon the type of cancer, or even if it's a significant dysplasia within the breast, we want to know the extent of that. That may not be seen on a mammogram or be able to be determined ultrasonographically. We'll do an MRI to give us the extent of disease. It also lets us know maybe if there's something else in the other breast or whatever. So it's a very exquisite tool, very high tech. It's a lot more expensive, which is why we don't tend to use it as a screening exam, but it can give us a lot of information.
Well, out of all the things radiologists does, it seems like early detection of a breast cancer could be very rewarding.
Oh, it's life-saving.
But it takes a patient and knowledge to know when there's a problem and actually to come in and get this screening test.
That's exactly right.
Well, let's move to another question. This is from Pete, and Pete lives in Iowa. And he says, I am scared to death of developing a malignancy. What are things that I should be done to be screening? He's 58 years old, and he's just concerned. I guess this is such a good question because, you know, malignancies claim, which are malignancies to screen for, which are ones we don't screen for, in a 58-year-old man. And I guess we don't have to talk about breast cancer here, or do we?
Well, it's interesting. You know, I think the last year we had statistics, there's about 186,000 breast cancer diagnoses in women in that year. There was 1,800 breast cancers in men the same year.
Wow.
So it is something. Typically in men, it's going to be, you know, something that's going to be palpable, but in many times it's a more advanced stage in male because we deny it, we just disregard it or whatever. You know, many of the things that we screen for, some imaging-wise, some not. Of course, you know, for men, prostate. That's not a screening exam. That's just going to be a blood test. The #1 cancer killer in the United States is lung cancer. You know, typical screenings have previously been, we get a chest x-ray every year. You may get a sputum where you try to cough something up and send it off. chest X-rays are have a very low sensitivity for the detection of a cancer until it's big enough to be seen easily. CT scanning is something that people have suggested may be the next way of screening patients for that. There's a big national study going on right now to try to determine what benefit it has and in what patient populations is going to be most effective, particularly people with certain environmental exposures, asbestos and the like, smokers or former smokers, people who have high secondhand smoke exposure, even if they're not a smoker, but a family member may. But those are things that we're going to find out with this, particularly the lung cancer CT screening. You know, the disadvantage of screening everybody is expensive, and it's just an unbelievable expense. And one of the other disadvantages or negatives about a screening exam is there's a certain number of people that will have a finding that appears to be positive and then goes through a tremendous workup that turns out to be a negative or a benign thing. Right. That can happen with breast cancer. That can happen in mammography and in breast imaging. That can happen, you know, with CT scanning. We find a little nodule, not really sure what it is, so we want to look at it closely, or we biopsy it, or we send the patient to their surgery to do a wedge resection of that segment of lung, and it turns out it's a non-calcified granuloma. We cure them of their granuloma.
Right.
But, you know, the cost of that and the potential hazard to the patient, because, as you know, whenever we interact with a patient doing any sort of a procedure,
bad things can happen.
Bad things can happen.
Right. So you want to balance. So you know, he needs to screen for prostate, lung cancer. What about colon cancer? How would you screen for that? I've heard about these pills that you swallow and it takes pictures of your colon. I think that's what I'd vote for me.
But you know, I'm not a gastroenterologist, but the little camera that people swallow tends to be used for the small intestine.
Okay.
You know, colon cancers are from the large intestine or the colon. And the two ways that people screen for that is typically either a colonoscopy or a new CT exam that's coming out called virtual colonoscopy.
Oh, tell us about that.
Well, it's an interesting technology in that the patient goes through the same prep that they would for a colonoscopy. You have to drink that stuff. It kind of cleans you out because we want to make sure that there's no residual material or anything in the colon. And then we image the patient laying actually supine and prone. We do have to put a little tip into the rectum and insufflate some air to distend the colon. One of the big advantages of colonoscopy, and I think in general it's recommended that at age 50 people start having a colonoscopy, then every 5 years after that, unless you have polyps. We do a virtual colonoscopy on you and we find a polyp. We can't take it out. We can't virtually take it out.
Right. But you know it's there.
But we know it's there. When you have a colonoscopy, not only are they screening it, but also if there's a polyp there, they can take it out.
Right.
Yeah, when I turn 50, I'm going to have a colonoscopy. And I've not had a virtual colonoscopy. It's something that I think is in particularly selected patients that may be difficult to instrument with a colonoscopy. We do some, particularly if they do if they can't get all the way through the colon, we'll surveillance a portion of the colon for them. I think it's a great test that we can use in combination. But you do that again, I don't think it's all or nothing. You do that in consultation with your doctors and what they think may be best on your situation.
So this is a fellow that's very concerned about malignancy. Looks like he needs a colonoscopy, you know, prostate exam and blood work. You know, maybe if he's in high risk, you know, consideration of a CAT scan or chest X-ray in his lungs. Are you ever seeing patients that are at risk that just get these full body CT scans that are paranoid about different things? Does that useful for anything? I know it's not cost effective, but is it really useful, or does it bring up more questions than answers?
You know, it was interesting. A number of years ago, that became almost, you know, probably around 1999, 2000, 2001, there was a lot of stuff in the press. I think Oprah was doing it. Lots of people were doing things about having these whole body screening exams. Somebody come into a imaging center or someplace, they pay a flat fee and they get scanned. We had a lot of interest in my community where I practice, and we actually did some of those. And the patients enjoyed the experience, hopefully got some good information. Because the overall incidence of cancer in general is very low, you know, the expense of that and then the potential side effects being at finding that incidental finding that is abnormal, and the radiation exposure has led that to be not something that is used very often.
Wow, this is very fascinating. And, you know, malignancies are such a major killer in the United States. I'm glad we talked to it. And, you know, one patient that I remembered not too long ago, he had end-stage lung cancer, and there was no cure. He had undergone everything he can. And I remember came to the office, and he says, you know, I just feel so bad. And, you know, one of the things that I was glad, I says, you know, we know that even though you have cancer in modern medicine, God hasn't chose to heal you that way. But God also has ways to heal, and one of the ways to heal him was love. And we turned him on to love of his Savior, got him back to real healing, and he passed peacefully, knowing that he had love in his life and he had hope in the future. So, you know, if someone's out there with lung cancer or any type of malignancy, there's hope. Thank you for joining us today on At the Heart of Health.